Hello, and welcome to today's event, Immigrant Health, Evidence, and Policy Issues. My name is Alan Weil. I'm Editor-in-Chief of Health Affairs. We're so happy to have you with us today. This is our second event devoted to the July 2021 thematic issue of Health Affairs, which was called Borders, Immigrants, and Health. Last week, we took a close look at health policy and humanitarian issues affecting people on both sides of the US-Mexico border. Today, we're going to focus on immigrant health, looking at health and healthcare for immigrants in the United States. Now, about 1 in 7 residents in the United States is an immigrant, and there have long been documented significant disparities in health status between people born in the United States and those who've immigrated. But the demographics of the immigrant population in the United States have changed dramatically in the last few decades. This is due to multiple factors, including the loss of economic opportunity during the Great Recession, changes in immigration policy and other policies as they relate to immigrants, and the effects of violence, political dysfunction, climate change, and other global factors that affect people's ability to make a living and live safely in the countries where they're born. Today, we're going to do what we often do at Health Affairs for an event. We're first going to hear from authors of 5 studies that were published in the July issue. They're going to cover a range of topics, everything from how non-citizen children compare with citizen children living in the same families in the United States, to how enforcement of immigration policies has reduced services for for various safety net programs, and much more than that. We'll hear from each of our authors, and then we'll be joined by Dr. Elaine Batchelor, CEO of MLK Community Healthcare in Los Angeles, to talk about what it means to serve a community that has a very large number of immigrants. And we'll bring all of our authors and our speaker back together to answer your questions and some of mine. Now, if you look below the video window, you'll see a form for questions. I encourage you to submit your questions at any time. In fact, the earlier you do it, the easier it is for me to try to weave it into my portion of the agenda. I'll do my best to include what you submit during the closing half hour of the event. Of course, putting together an issue like this and an event like this takes a great deal of effort. I want to acknowledge the financial support of the foundations that supported the issue in this event: the California Healthcare Foundation, the California Endowment, and the Con Alma Health Foundation. And I will say it many times, but I particularly want to thank our theme issue advisor, Arturo Bustamante, professor of health policy and management at the UCLA Fielding School of Public Health, who went above and beyond in helping us make sure that this issue was a success. So before we begin with the program, I'm going to turn it over for a quick few words from Denise Herrera, Executive Director of the Con Alma Foundation. Denise Herrera is Executive Director. As I said, she, prior to that, was the Senior Capacity Building Officer at the St. David's Foundation, which is the largest health funder in Texas. And I remember her from when she was working in research and evaluation at the Robert Wood Johnson Foundation. Well, we're grateful for your support of this issue, along with the other funders. Denise, I'll turn it over to you for a few opening remarks.
Thank you, Ellen. So again, my name is Denise. My pronouns are she and her. I'm the new Executive Director with Con Alma Health Foundation, which is located in Santa Fe, New Mexico. At Con Alma, we seek to improve the health status and access to health services for all New Mexicans, and we advocate for health policies that address the unmet needs of those in our state. We are a 20-year-old foundation that has always focused on health equity, even before health equity was cool. So we were honored to sponsor this issue of health affairs for several reasons. First, we know that people in America are forced to live in fear because of their immigration status. And their health and the health of our nation suffers because of that. So overall, immigrants have lower rates of health insurance, they use less health care, and they receive lower quality of care than US-born populations. Immigrant families often fear interactions with public agencies, which means that they forego needed health care and social services. Second, fear of deportation has a significant impact on the non-medical services, such as food assistance, that are also important to good health. Toxic stress associated with the fear of deportation has harmful effects on long-term physical and mental health. And last but not least, in philanthropy, we have a responsibility to tackle root causes and change systems. There's less red tape in philanthropy than in other sectors. So above and beyond grant making and serving as a neutral convener, we have a platform for sharing stories and data. Sponsoring special issues like this is just one way for us to help advance health equity for all. It's hard enough to access health and human services for US-born, English-speaking communities. The burden placed on our immigrant neighbors is unnecessary and inhumane. At CONAMA, we believe that instead of praising people for being resilient, we need to change the systems that are making them vulnerable. So I look forward to the conversation. Thank you for including CONAMA Health Foundation today.
Thank you, Denise, so much for those remarks and for your support that has made this issue and event possible. We'll now turn to presentations from our authors. These are all papers that were included in the July 2021 issue. Each presentation can only cover so much ground, so I'd encourage you to look at the papers themselves if you have additional questions. I'm going to go ahead and quickly introduce all 5 of our presenters so that I don't have to interrupt the flow, and then I'll turn to them each sequentially. You'll hear first from Arturo Bustamante. I already introduced him as Professor of Health Policy and Management at the UCLA Fielding School of Public Health, and as I have also mentioned, he was our theme issue advisor. You'll next hear from Dolores Acevedo-Garcia, the Samuel F. and Rose B. Gingold Professor of Human Development and Social Policy, and the Director of the Institute for Child, Youth, and Family Policy at the Heller School for Social Policy and Management at Brandeis University. You'll hear from Brandy Lipton, an economist and assistant professor in the Division of Health Policy and Management at San Diego State University. Leighton Koo will be next. He's professor and director of the Center for Health Policy Research at the George Washington University School of Public Health. And Leighton and I were colleagues some years ago at the Urban Institute. And Sharon Tao, senior project manager and epidemiologist at the Institute for Community Health, an organization founded jointly by the Cambridge Health Alliance, Mount Auburn Hospital, and Massachusetts General Hospital. I'll now turn it over to Arturo to kick us off.
Well, thank you very much for having me here today. I'm very honored to participate in today's event. In this brief presentation, I will discuss the main highlights of our paper, which provides an overview of recent demographic changes among U.S. immigrants, examines recent health and healthcare inequities between immigrant and U.S.-born adults, and it identifies key areas where policy change is needed to improve access to healthcare among underserved immigrants. I would like to start my presentation by acknowledging my co-authors, Ji Chen, Lucia Felix, and Alex Ortega. Next slide, please. Since the 1960s, the immigrant population in the US has increased fourfold, reaching to 44.7 million immigrants in 2018, or 13.7% of the US population. This is consistent with early historical figures when the immigrant population fluctuated between 13 and 15% of the overall US population. Next slide, please. The racial and ethnic composition of US immigrants has also changed. Until the 1970s, US immigrants were overwhelmingly of European origin. But starting in the 1980s, US immigrants have been more likely to originate in Latin America and Asia. Changes in the demography of immigrants are likely to continue in the upcoming decades. If present trends continue, immigrants from Asia are projected to become the largest group of immigrants by 2055. Next slide, please. The changes in the US economy after the Great Recession of 2008 and recent shifts in immigration policy have led to important changes in the profile of US immigrants. The first noteworthy change is a rapid decline of low-skilled immigration, particularly the undocumented immigrant population. The undocumented immigrant population reached a historical maximum of 12.2 million in 2007. But its numbers have been in decline since the Great Recession. In 2017, approximately 10.5 million undocumented immigrants lived in the US. Something important to note is that close to half of all undocumented immigrants live in 3 states, California, Texas, and New York. However, in our paper, we note that in the last 2 decades, immigrants have started to settle in states that were not traditional immigrant destinations. Next slide, please. In our study, we analyzed recent health and healthcare data. Consistent with previous research of immigrant health and healthcare, we observed that immigrants are more likely to have better self-reported health status and lower incidence of chronic health conditions compared to US-born adults. These differences, however, narrow based on citizenship and documentation status. For example, non-citizen immigrants who have lived in the US for less than 5 years report better health outcomes compared to naturalized and US-born adults. In the article, we argue that a more nuanced study of immigrant health should look at particular groups of immigrants who may be vulnerable to specific health conditions. One relevant example is the early evidence from the COVID-19 pandemic, which has disproportionately affected low-income Latino immigrants. Next slide, please. In our study, we also examined recent trends in health insurance coverage and access to healthcare from 2004 to 2018, accounting for socioeconomic and demographic differences between immigrants and US-born adults. This is a period that includes 2 key events that had important consequences on immigrant health coverage: the Great Recession and the nationwide implementation of the Affordable Care Act. Our data analysis shows that healthcare inequities increased after the Great Recession, but later the implementation of the Affordable Care Act reduced some of these inequities. We identified 3 key predictors of health insurance coverage and access to healthcare among immigrants: length of US residence, documentation status, and English language proficiency. In our research, we also find that differences between undocumented immigrants and US-born adults are the more widespread. Next slide, please. One of the main takeaways of our study is that in spite of that positive impact of the ACA, immigrants are still less likely to have health insurance coverage and have worse patterns of access to healthcare compared to US-born adults. For example, we find that the probability of being uninsured for non-citizen immigrants who have lived in the US for less than 5 years decreased from 11.2% before the Great Recession to 6.6% after the Affordable Care Act implementation. Similar changes were observed when we looked at other measures of healthcare access and use, such as reporting a usual source of care. In our study, we recommend that immigration reform should close the coverage gaps left by the Affordable Care Act among US immigrants, particularly in states that have not expanded Medicaid. Next slide, please. Next slide, please. One of the main demographic changes highlighted in our study is the accelerated rate of population aging among immigrants. This process is likely to have important policy implications if present trends continue. In fact, the aging process among immigrants is currently faster than the aging process of the US-born population, since immigrant age cohorts above 50 years of age are growing at much faster rates than the corresponding cohorts of US-born adults. From a health policy perspective, the US healthcare system is largely unprepared to deal with aging immigrants, particularly uninsured immigrants who live in states where they are ineligible for Medicaid and undocumented immigrants who are ineligible for Medicare. Next slide, please. To conclude, our study recommends increased access to affordable health insurance coverage to help protect immigrant household incomes and encourage optimal access to healthcare. While we acknowledge that the odds of comprehensive immigration reform are low, in our study, we provide examples of incremental reform at the federal, state, and local levels that can partially expand healthcare to underserved immigrants. Thank you very much for your participation in this event, and I encourage you to check out our full publication for more detailed information.
Thank you so much, Arturo, for kicking us off. And I agree, there's much more detail in the paper. We'll turn now to Dolores Acevedo-Garcia. Dolores?
Thank you, Alan. Our presentation today is going to focus on the exclusion of children in immigrant families from the social safety net. If you can show my slides, please. First, we define immigrant families as those with at least one parent who is foreign born. The main takeaway from my presentation is that the exclusion of children in immigrant families from the social safety net, which is a manifestation of structural racism, hurts the health and development of these children. There are compelling equity and demographic reasons for including children in immigrant families in the social safety net. First, children in immigrant families are 26% of US children. They are 43% of all children in poverty, which really underscores that we cannot design effective anti-poverty policies without addressing their needs. Very important, 91% of children in immigrant families are US citizens. However, 75% of them live in mixed status families. That is, families in which at least one member of the family is not a citizen. Next, sorry, that slide is fine, sorry. Children in immigrant families have much higher poverty rates than children in all citizen families. This bar chart is showing that US citizen children in families with undocumented members have a very high poverty rate of about 32%. Their poverty rate is as high as that of undocumented children living with undocumented parents, which suggests that for children of undocumented parents, being US citizens themselves doesn't buy them much in terms of experiencing lower poverty. Next slide, please. So why is this? An important reason is that children in immigrant families are excluded from the social safety net. How are they excluded? A number of different ways. First, there are categorical eligibility exclusions based on immigrant status and membership in an immigrant family. Second, income eligibility is stricter and benefits are lower than for other families. And third, participation is lower further beyond eligibility restrictions because of both high administrative burden and a heightened anti-immigrant climate that has resulted in a stronger connection between immigration policy and use of the social safety net. For example, the proposal by the previous administration to expand the definition of the so-called public charge. Next slide, please. I want to give you a sense of the magnitude of the number of children excluded. Children in families in which all members are citizens are the majority of children in poverty. But the second largest group of children in poverty in the US today is citizen children with undocumented parents. 17% of children in poverty are US citizen children living with undocumented parents. Next slide, please. Let's look really briefly at one of the examples that we discuss in the paper. One of the most important anti-poverty programs that we have in the US is the Earned Income Tax Credit, or EITC. Our child poverty rate is about 13%. Without the EITC, it would be about 19%. Next slide, please. The exclusion of children in immigrant families from the EITC has very real implications for both families and for poverty reduction. Let's look really briefly at two nearly identical families. Both have two working parents, both have two US citizen children of the same ages, and both have an annual income of about $25,000. For tax year 2020, the first family, which has two parents with Social Security numbers, received a total of nearly $6,000 from the EITC. The second family did not receive the EITC at all, even if only one of the parents didn't have a Social Security number. By the way, the American Rescue Plan does not address this exclusion from the EITC. Next slide, please. So why is this? As we discuss in the paper, immigration status legality has become an important determinant of child health. We define immigration status legality as a form of structural racism that classifies immigrants into categories and assigns these categories different degrees of deservingness and access to social programs such as the EITC or SNAP that help reduce child poverty and improve child health. Initially, the construct of illegality as a social determinant of health was centered on undocumented immigrant status. However, more recently, it has been recognized that it functions as a continuum of health vulnerability that reflects the precariousness and lack of access associated with lack of citizenship. This includes multiple immigration status, not only undocumented status. Legal immigrants in the US also have restricted access to the safety net. They must wait for 5 years before obtaining what's called qualified status to be used in social programs. And as we just saw in the example of the EITC, US citizen children in immigrant families also have restricted access to the safety net. Very importantly, immigrant exclusions have been implemented with both an anti-immigrant and anti-Hispanic animus. And they disproportionately hurt Hispanic children, who are much more likely than other children to live in low-income immigrant families. Next slide, please. Okay, so to end, what can we do about this? How can we fix these inequities? This is the policy area where what we have to do is pretty clear and makes sense if we want to reduce child poverty equitably. We need to look across all social policies and address immigrant exclusions, but let's talk a little about the EITC. We should restore eligibility for the EITC for tax filers without social security numbers. This was the status quo before 1996. And we can start with those that have children who have social security numbers. We should do the same with relief and recovery measures such as the one that we implemented during the pandemic. Another area where we need change is eliminating the 5-year bar on the use of safety net program by legal immigrants. And finally, I want to mention some state actions that are important. Many states have their own EITC. There are states like California and Colorado that have implemented expansions to include tax filers without social security numbers in their EITC. There are states that also took measures during the pandemic. For example, California expanded healthcare coverage for undocumented immigrants, which made sense not only from a health equity point of view, but from a public health point of view. So these are just a few examples of the types of changes that we need to apply across all safety net policies if we are serious about reducing child poverty equitably and about including children in immigrant families, again, 26% of our child population. I hope we can discuss this more during the Q&A. Thank you very much.
Thank you for that presentation. We'll now turn to Brandy Lipton. Brandy?
Thanks so much, Alan. So I'm going to be talking today about California's 2016 Medicaid expansion to undocumented children. And this work is co-authored with my former student, Jefferson Nguyen, and my colleague, Melody Shafino. If you could change the slide, please. Medicaid and the Children's Health Insurance Program are major sources of health insurance coverage for children in the US, but undocumented children generally aren't eligible for those programs in most states. And that likely contributes to the large coverage disparities between children by immigration status that still exist today in the US. California expanded Medi-Cal in May of 2016 to cover children in low-income households regardless of their immigration status, and they were the 6th state to do so. In this study, we used 2012 to 2018 American Community Survey data to examine changes in health insurance coverage and source of coverage before and after California's expansion, and we used 2 comparisons in our analysis. First, we compared low-income non-citizen and citizen children. Like most data sources, we weren't able to directly observe undocumented status, so we used citizenship as a proxy, and we expected that non-citizen children would be much more likely to be affected by California's expansion. Second, we compared California with 12 control states, and those states were selected because they were more similar to California in terms of their public health insurance policies for immigrant populations. 5 of those states actually provided comprehensive public health insurance benefits to undocumented children already, beginning before the start of our study period, and the other 7 did not. Next slide, please. This graph shows rates of any health insurance coverage among low-income children by citizenship status from 2015 using American Community Survey data. This was the year before California's statewide expansion to undocumented children. Starting from left to right, The leftmost set of bars shows the difference in rates by citizenship status for the whole United States. The next set of bars shows the difference in rates for California. And then the following sets of bars shows the difference in rates for the control states. And the control states are split into two groups. States with child coverage are the 5 control states that were already providing comprehensive public health insurance benefits to undocumented children. And the states without child coverage were the other 7 control states. At the national level, there was about a 26 percentage point gap in having any health insurance coverage, so that's public or private coverage, by citizenship status. Low-income citizen children, there were about 94% that had any source of health insurance coverage, compared to only about 68% of non-citizen children. In the 5 states that were already providing comprehensive public health insurance benefits to undocumented children, there was only about a 6 percentage point gap by citizenship, so quite a lot smaller than at the national level. California was in between with about a 16 percentage point gap. And that may be because some undocumented children in California did have coverage options. Some counties were operating children's health initiatives and their own local health insurance product called Healthy Kids to cover children who weren't otherwise eligible for Medi-Cal, including some undocumented children. Though enrollment in those programs had declined by 2015, the year before California's statewide expansion, because of some new program restrictions. So they were covering fewer children, but some children did have those options. Next slide, please. This table shows the results of our analysis, and for more details, please see the paper, but the basic idea is just comparisons of health insurance coverage for non-citizen relative to citizen children before and after California's expansion in California relative to the control states. So I'll focus on the 2017 to 2018 results in the second column and the top panel, which shows the results for all California counties. Our findings suggested that by 2017 to 2018, California's expansion resulted in about a 9 percentage point increase in rates of any health insurance coverage among low-income non-citizen children. And that increase was driven by about a 12 percentage point increase in Medi-Cal, as you might expect. There was also about a 3 percentage point reduction in rates of private coverage that wasn't statistically significant at conventional levels. We also looked at whether results differed by whether a county had a children's health initiative in place as of 2016 or whether they did not. So by 2017 to 2018, those 2 sets of counties with and without an active children's health initiative were pretty similar in terms of the increase in any health insurance coverage among low-income non-citizen children. What we found was that counties that had an active children's health initiative seemed to see increases in any health insurance coverage a little sooner, even as of 2016 in that first column, whereas the counties without an active CHI did not. To conclude, California's 2016 expansion was associated with substantial gains in coverage among low-income non-citizen children. The 9 percentage point increase in any health insurance coverage that we estimated translates to about a 34% reduction in the uninsured rate among low-income non-citizen children. We found that coverage increases occurred a little more quickly in counties that had an active children's health initiative as of 2016, even though enrollment in the local health insurance product in those counties had declined quite a bit before the statewide expansion. It's possible that those counties had more experience with enrolling children in this group in health insurance coverage, and they may have been able to respond more nimbly to the statewide expansion. Our findings also translate to a substantial reduction in health insurance coverage disparities by child immigration status, which still remains substantial in the rest of the country today. Thanks so much.
Thank you for that presentation. We'll turn now to Leighton Koo. Leighton?
Hi, thank you very much, Alan. And I particularly want to say I appreciate being preceded by Professor Acevedo-Garcia and Lipton. The talks they gave really are quite directly relevant to what I'm talking about. So maybe we can go to the first slide, the header slide. So my paper, and I should say it's not just my paper, In fact, I am merely the presenter. The lead author is my colleague, Mary Ellen Jewers. Actually, the genesis for this paper began as their doctoral dissertation, but so that we could sort of bring it up to date and make it worthy of health affairs, we did a lot of work on it since then. But really, the core is, again, focusing on immigrant children. And in particular, we do two things, but one of the things we really try to focus on is looking at siblings, looking at non-citizen versus citizen siblings. And part of this reflects an equity issue. So maybe we can turn to the next slide. So we began by really having sort of two studies that we're talking about in our project. One is the main paper, which is a fairly sophisticated analysis, though it was done in a fairly straightforward way. What we really did was that we compared non-citizen children and their citizen siblings in mixed status families. And as you heard already, this is very common. This is a common situation for immigrant families in the U.S. In fact, I'll say this is my own personal experience. My sister was foreign born. I was born in the U.S. So, as we look through these data, this reflects in part my personal history. The data we used came from pooled data from 2008 to 2018 for the National Health Interview Survey data. And in particular, one of the things that's useful about that survey is it has information about all the members of a family with a little bit of information about their health insurance status, their citizenship status, and so on. We used a fixed effects family level models. And what this means is that essentially speaking, we control for every single family in our analysis, and in total, just so you know, there are around I think 8,400 children and around almost 3,000 families in our sample. By using the fixed effects methods, what we can do is that we can basically say we're netting out all the shared family and state local characteristics. That is, we're within a given family, we're saying, okay, we're making everyone in that family will control for all those unique elements. So this controls for differences in family background, income, parental status. It also controls for to the extent to which there are state or local policy differences. So, for example, some states offer Medicaid to certain lawful permanent resident children. Other states have a 5-year bar. Some states, as you've heard, actually provide coverage for undocumented children as well. Again, because we're always looking at the same families, all those factors are controlled for. This also controls for unmeasured factors that may be going on. So it's aspirations within a family, the extent to which a family wants to have coverage for their children, so on and so forth. What we can do, however, is we can focus on situations where there are the differences between siblings. So here there were 3 principal differences that we examined for siblings within the same family. One, what's their citizenship status? So some children are non-citizens, some children are citizens. We did not look at, we didn't have the detailed information about what kind of non-citizens they are. That is, are they undocumented? Are they LPRs? Whatever, all that status. We're just calling them citizens and non-citizens. We also control for age and gender. And I will mention that generally speaking, again, thinking of the situation for my own sister, the foreign-born child, the non-citizen child, typically is older. It's the U.S.-born child was born later, so typically they're a little younger. And then also their gender differences. Once again, my sister's a different gender than me. The net effect of having this fixed effect system where we can control for all the characteristics within the family is it provides fairly strong evidence of causality. We don't think that the differences are because of income, race, ethnicity, parental status, local state or local policies, etc. That's not to say that state and local policies don't matter. They do matter, but nonetheless, they're not what are causing the differences within our own analysis. The second analysis was a much simpler analysis, and really we were trying to use census data to examine the extent to which adults who entered the U.S. as non-citizen children transitioned to citizenship. And so this was another way that we sort of wanted to look at an equity issue. Next slide. So the key results of that first analysis of the fixed effects family model is that we found that non-citizen status is associated, well, I shouldn't even say associated with it, leads to lower insurance coverage and lower access to care. What we found very clearly was that non-citizen children were 26 percentage points more likely to be uninsured than their citizen siblings. This is roughly triple the risk. We were using linear probability models, so that's why I say the percentage point. If we used odds ratios or something like that, we'd be talking about a triple the risk impact. At the same time, we had almost exactly the same difference in the likelihood of having Medicaid or CHIP, a 26 percentage point difference. I'll mention, by the way, I heard this magic number 26% also come up in Brandy Lipton's presentation just a few minutes ago. So this is showing some correspondence between the data that we had from NHIS and the analysis that she had using the ACS. We didn't find any significant differences in private insurance. And why this is relevant is in private insurance, citizenship status doesn't matter. So if this suggests that parents, immigrant parents where the children have different citizenship status, they tend to cover their children in the same way. Parents' preferences would be to treat their children equivalently. We do find slight differences in insurance status that are related to age. Older children are a little bit less likely to be insured than younger children. On the other hand, that difference is really quite trivial compared to the much larger impact that's associated with citizenship. We also could look at delays in healthcare due to cost. And we found that the delays in healthcare due to cost were twice as common among the non-citizen children as for their citizen siblings. And that this was mostly due to insurance differences. In fact, when we control for the insurance differences, there are no longer differences in delays in healthcare. So it's really the health insurance differences are what are mediating that effect in the delays in healthcare status. We also looked at health status. So this is self-reported health status, excellent, very good, good, fair, poor. There were no significant differences in the health status for the citizen and non-citizen siblings. And partly this is simply because most of the children were in excellent health. And this is the fortunate thing for most children. Most children are in excellent health, so we don't see much of those differences, though there's other research that does show where there are health differences that occur. Next slide. So in the second analysis, we used data from the 2020 current population survey. And really what we did was we took a retrospective view. We said among the US adults who were reporting in the 2020 CPS, who say that they entered the US as non-citizen children. That is, they were 18 or younger when they entered the US, they were not citizens. So again, children who, adults who, whatever their status, came in as non-citizen children. We tried to figure out how many were citizens by the time that they were 30 or older. In fact, we looked at a number of age ranges. We just choose 30 because it's convenient. 70% of the children became citizens by the time they were 30 or older. So the point is, essentially speaking, non-citizen children usually grow up to become American citizens. So I will note that this analysis excludes some children who may have entered as non-citizen children, but then leave before their adult years. They're not captured as adults in the CPS. On the other hand, we've looked at some other data that tries to look at the dynamics of coming and going and find that that mostly seems to be occurring among adult workers, not so much children. In particular, the case that we're talking about are situations where there's one child who's a US-born citizen. So we don't think that that's likely to affect that statistic. So the final issue then is the policy challenges. And so really what I want to stress here is what was driving both these analyses was, essentially speaking, an equity issue. The first equity issue is, should children from the same families be treated the same? Should we treat the citizen child and the non-citizen child the same? Shouldn't they have equal access to health insurance and healthcare? And I'd argue, I think that not only are we showing that right now, the citizenship difference, which is basically entirely driven by policies that we set up in the US, saying that we would treat the non-citizen children different than the citizen children. So it's a policy difference that we constructed. And the question is, why would we want to construct barriers that make children in the same families be treated differently? I don't think that's what parents want. That's certainly what we saw from the experience when we look at private insurance. Parents didn't try to distinguish the insurance coverage or the access to care for their citizen and non-citizen children. I don't see why, as a policy, the US would want to do that. Second question is an equity issue of what's the future status? Right now, we determine citizenship status based on the fact that the children are not citizens right now. But again, the data that we have suggest that children usually grow up to become citizens. And so in that regard, to the extent that we jeopardize their current health insurance status, their current access to health care, we are harming future citizens if we deny coverage early in life. There are other studies that have shown that there are beneficial impacts when people have Medicaid early in life, that this helps them as they become adults. So certainly this somewhat contrary view that we want to deny future citizens coverage can have adverse effects. So we had some simple recommendations. One that's become a little more relevant in the past week again after Judge Hainan's decision is we should extend DACA. And in fact, we'd argue you should provide public coverage to DACA recipients as well. The second, which is broader, is that we really should consider eliminating child immigrant restrictions on Medicaid. Some of that, states all have the option to get rid of the 5-year bar. About half the states have done so, the other half have not. That would be something that could be done under law. Right now, every state has the option to do that. And many states could consider going more broadly, as California did, as Brandy Lipton just described in her study. Certainly, there's reasons to think that this is something that can be beneficial to those children, help improve their insurance coverage, improve their status of care, and that, frankly, we think is just more equitable and ultimately helps future citizens. Finally, we do note, and we're happy to know that President Biden has already canceled the public charge rule. So that eliminated one threat that has gone on, though there is still a rulemaking process that's going on, but that public charge rule has already been rescinded. So that's it for our recommendations. Thank you very much. Bye.
Thank you, Leighton. And I'll now turn to Sharon Tao. Sharon?
Hi. Thanks, Alan, and thanks to Health Affairs for organizing this panel. And I just want to say thank you to the California Healthcare Foundation who funded our work. I need to first begin by acknowledging that I'm presenting on behalf of my colleague, Leah Zalman, who many of you may have known personally or by her reputation as a scholar in this area. She was the ideas and the foundation behind all this paper, and we just carried out her work. So if you could turn to our slides, if they're there, that'd be great. Thanks. She passed away in November 2020 after being hit by a car as she walked home after voting in the November 2020 presidential election. Next slide, please. Leah wrote these words about a week or so before she passed away, and these words are really a reflection on both National Immigrant Day and her thoughts about the upcoming election. The ideals represented in these words are at the core of this paper and this work, and really embodied all the work that she did as both a physician and a researcher. She dedicated her career to advancing immigrants' health and to conducting research that documented the unfairness of a society that will readily accept immigrants as both taxpayers and workers, but denies them basic human rights. Next slide, please. This paper explores the intersection between the public charge rule proposed and implemented under President Trump, as many have already talked about, and the COVID-19 pandemic response, which urged essential workers, a disproportionate share of which are immigrants, to continue to go to work and incur risks of COVID-19 infection. We estimate the number of immigrants and their household members who may have foregone Medicaid and SNAP food stamp benefits due to the chilling effects of the public charge rule at the outset of the COVID-19 pandemic. As early as 1882, entry could be denied to immigrants deemed unable to care for themselves and likely to become a public charge. The rule was clarified in 1999, and determination would be based on federal means-tested benefits that included cash, such as SSI, but would exclude benefits for food assistance and health care. Anyone who uses any of these cash-based benefits may be determined likely to become a public charge and then subject to immigration sanctions. President Trump's proposed rule change, which was announced in 2018, hotly debated and implemented in February 2020, expanded the scope of the public charge determination to include non-emergency Medicaid and SNAP, as well as housing subsidies. The circulation of inaccurate information about to whom and to which benefits the rule change applied, along with fear about the implications of the rule, resulted in a chilling effect. Immigrants and their family members, including those not subject to the rule charge determinations, withdrew from the safety net. We applied a Department of Homeland Security definition of essential workers that was released in response to the pandemic to occupation codes in the American Community Survey from 2019 to estimate the number of immigrant and US born essential workers, both in the US and then in the 4 border states with Mexico, Arizona, California, New Mexico, and Texas. We identified nearly 20 million immigrant essential workers. They made up a disproportionate share of the essential workforce. While they make up 16.6% of the US adult population, they make up nearly 18% of the adult essential workforce. We relied on estimates from the Wellbeing and Basic Needs Survey in 2019 that found that between 16 and 32% of immigrant families were already avoiding benefits prior to the rule implementation. Since the survey was only conducted in English and Spanish and the exact timing of the chilling effect was unknown, we present a range of disenrollment scenarios for Medicaid and SNAP at 15%, 25%, and 35% disenrollment. We define those at risk of sanctions as non-citizen essential workers and their household members, as decisions about engagement and benefits often happen in the context of households and families. We identified more than 31 million essential workers and their household members who were determined to be at risk. 41% of those in this group had incomes below 201% of the federal poverty level. Next slide, please. We estimate that at the start of the pandemic, nationally, between 1.2 and 2.9 million essential workers and their household members may have foregone Medicaid benefits. Between 0.8 and 1 million may have foregone SNAP benefits. These results reflect what leaders in the immigrant community have reported, that immigrants are struggling with supporting their families during the pandemic, but are reluctant to apply for SNAP or other benefits out of fear of public charge implications and immigration enforcement. Immigrants play a large role in the essential workforce of the 4 border states as well, where 7.4 million immigrants account for nearly 30% of the adult essential workforce. Across the 4 border states, ranges for disenrollment are between 0.6 million and 1.4 million for Medicaid, and between 0.3 million and 0.8 million for SNAP. And as the Inku already mentioned, the rule has been rescinded with President Biden's election to the office, thankfully, but there is early evidence that suggests that the chilling effect will not just immediately disappear, but will continue. And some investment will be needed in communication and outreach to immigrants and trusted immigrant serving organizations in order to educate immigrants and those who serve them in what the current rule is and the implications for that rule are. The Department of Homeland Security and their guidance around essential workers maintain that certain critical infrastructure industries have a special responsibility during the pandemic to continue their operations. Immigrant essential workers in the sectors of agriculture, food production, healthcare, and other key sectors showed up and continue to show up for work throughout the pandemic so that the rest of us have access to the resources that we need. We therefore have the responsibility to these workers and their families to ensure that they have access to the basic human rights of healthcare, adequate nutrition, and affordable and safe housing. Thanks again to Health Affairs, California Health Care Foundation, my co-authors, and to Leah for inspiring us to continue to advocate for inclusionary health and immigration policies. Thanks.
Thank you, Sharon, and I appreciate your recognition of Leah, who also participated in our planning meeting for this issue, and so was an important force for the whole issue, as well as being co-author on 2 of the papers. Before we turn to a discussion, I'm eager to bring in the voice of someone who is serving a population that confronts all of the issues that have been discussed thus far. We're going to hear from Elaine Batchelor, Chief Executive Officer of the MLK Community Healthcare, which is a health system that includes a state-of-the-art private safety net hospital, the MLK Community Medical Group, community and population health programs, and a fundraising foundation. She was formerly Chief Medical Officer of the LA Care Health Plan, which is the largest public health plan serving a safety net population. has been vice president of the California Healthcare Foundation, and was medical director for the LA County Office of Managed Care. She is a member of the Health Affairs editorial board, and so it's a particular pleasure to be able to turn to Dr. Batchelor for some comments. Elaine, the floor is yours.
Thank you, Alan. It's a pleasure to be here. And if I could have my slides started, please, that would be great. Thank you. It's been moving and familiar to hear the challenges facing immigrants today, and I applaud the excellent research and proposed solutions presented to better serve this population. I've worked most of my career to bring quality healthcare to underserved communities. And from every vantage, I've observed the same thing: separate and unequal healthcare systems contributing to health disparities for people of color. As I reflect on the challenges facing immigrants, I see parallels in the populations we serve at MLK Community Healthcare in South LA. This winter, our small community hospital was the epicenter of the South Los Angeles winter COVID surge. We had more COVID patients than hospitals 3 to 4 times our size. As the surge drew national media attention, we used the opportunity to talk about the reasons COVID hit South LA so hard. The community's decades-long lack of access to quality health care, compounded by other social determinants of health. Next slide. MLK Community Hospital opened in 2015 as a private safety net facility with a mission to provide quality care for the 1.3 million people who live in South LA. We serve a low-income community that is predominantly Hispanic and African American and has been medically underserved for decades. We don't ask or record our patients' immigration status, but we know that we serve many immigrants and that about 10% of our patients are ineligible for Medicaid due to their status. We opened our hospital with the conviction that our community deserves quality health care and the determination to provide it. As a result, we're in the top 10% of hospitals nationwide for patient satisfaction. We're at HIMSS level 7, the highest level of information technology use for hospitals, achieved by 6.5% of hospitals in the country. And we've received multiple A grades for patient safety from Leapfrog. We aren't located in an immediate border county, but our community experiences the same barriers to health described in the Health Affairs theme issue. Redlining, housing covenants, and discriminatory transportation policies turned South Los Angeles into a low-income minority community lacking essential determinants of health. Discriminatory healthcare funding policies have made it a healthcare desert where residents are unable to access the healthcare they need, while in adjacent, more affluent communities, healthcare is overconsumed. Next slide, please. Even before COVID, our community was experiencing an epidemic of poorly treated chronic illness driven by the structural barriers noted on the previous slide. The average community has 10 times more physicians than South LA. As a result of lack of access to care in the community, our small community hospital has one of the busiest emergency departments in the state. It was designed to provide 40 to 45,000 visits a year. In 2019, we provided 110,000 ER visits. Patients arrive in our emergency room in crisis with advanced conditions that are preventable and treatable with adequate outpatient care. Diabetes is an excellent example of what happens to a community that doesn't have adequate access to health care. One of the most shameful statistics on this slide is the fact that diabetic amputations and wounds are the most frequent surgical procedures performed at our hospital. Next slide. Structural and systemic disparities have created a separate and unequal system for our community. First, low quality health insurance limits access to providers. California leaders made a choice to expand coverage to most low-income households in our state, which I applaud. However, the reimbursement rates paid to providers are so low, it has constrained supply with dire consequences for communities like ours. As an example, an emergency room visit earns an average from private insurance of $2,000, $650 from Medicare, and only $150 from Medi-Cal. These low reimbursement rates have translated into a shortage of doctors, a lack of access to quality care, and the high rates of unmanaged chronic disease that we see every day. Our hospital receives supplemental funding for care that makes us financially sustainable, but outpatient providers do not. This is another one of the root causes of chronic illness that we see in our community, the underinvestment in outpatient community-based prevention and disease management. As a result, the emergency department has become a de facto medical home for many in our community. There are also inequities in funding of medical training that have made it difficult to diversify the health professions here. And we know that lack of diversity among healthcare professions makes it harder for providers to establish trusted relationships and to provide clear communication. Next slide. It's clear that health insurance coverage does not automatically translate to access. Adding people to the system without adding providers to serve them is counterproductive. Sacrificing access and quality for increased coverage solves one problem while creating others. These disparities can be fixed, but it won't be easy. We need to increase the number of providers who can practice in underserved communities by fixing the payment models that perpetuate unequal systems of care. We can start by reducing variation in provider payments. It doesn't cost less to care for people who live in poor Black and Brown communities. So why are we paying less? We should make Medicaid provider payments on par with Medicare payments and standardize these across the country. We found that there are plenty of providers of high quality who are willing to serve our community when offered market rates. We've been able to recruit these providers with help from private philanthropy, but we know that philanthropy is not a sustainable business model. We need equitable reimbursement from Medicaid. We need policy change. We also need to invest in preventive and community-based prevention and disease management. My health system is adequately paid to amputate a limb, but we are not adequately paid to prevent that amputation from being necessary. We need to raise payments for outpatient care so that we can attract the providers we need. We need to integrate medical and behavioral care because often these conditions go together and the medical conditions can't be treated successfully without addressing behavioral health challenges. We need to expand the pipeline of people of color going into the health professions, including medical specialists in underserved areas. Research shows that doctors are more likely to practice where they trained. So underserved communities need residency programs to train and retrain and retain physicians. Most federal training programs are funded through Medicare. As a result, our training program can earn $55,000 per resident, while training programs in more affluent communities earn $185,000 per resident. We also need to include social determinants of health like transportation, housing, and food access, but it's not an either or. We need to fund both these social determinants and access to quality care. And ultimately, we need to cover everyone in order to reverse the disparities that we wish to address. This is a moment of reckoning as we move toward the end of the pandemic. History has shown that bold efforts are often born out of eras of struggle. The Depression paved the way for the New Deal, Social Security. The Great Recession paved the way for the Affordable Care Act. I'm hopeful that our pandemic that has laid bare some of the health disparities that our country has been struggling with for decades will motivate us to make substantial changes in how we fund and structure healthcare in our country. Thank you.
Thank you so much for that presentation. I'm taken back to Denise Herrera's words at the outset that Konama was working on equity before it was cool. The equity issues that have come up here are so profound. And this is a dimension of equity that I think is often not included in the broader health equity conversation. So I hope we are helping to broaden that out. I have had a number of questions submitted from the audience and some of my own. I'll weave them together. I'm going to start. Someone asked about meeting the mental health needs of unaccompanied minors. I'm going to broaden the question. Elaine, you mentioned the high mental health burden. I wondered, where does mental health fit in these conversations? And if any of you as authors in your work have particular insights on the mental health dimensions, I'd be very interested to hear those as well. And just speak up or give me a little visual cue if you want to speak.
So I will start since you called on me. What we've learned in our time of operating our hospital and health system is that mental health is an integral part of healthcare. We are not a psychiatric hospital, but we quickly realized that we needed to be a provider of mental health services. 20% of the patients that come to our hospital come with primary mental health conditions and substance use disorders, and they are intertwined with their medical conditions. Like many other hospitals, we have boarded patients in our emergency department while waiting for beds that don't exist in other hospitals. And we finally concluded that we need to take care of these patients ourselves. So we've made every effort to integrate behavioral health with medical care in our hospital, in our outpatient practices, and in our population health programs. It's made more challenging by our policy of separate funds of streaming and separate delivery of mental health conditions. But we need to bring those two back together. It's also one of the reasons that we have so many homeless people in our county, the lack of access to treatment for mental health conditions.
Any other comments on this, or I'll move to?
I wanna add something about what the population level perspective. About 25% of Hispanic children in the U.S., 1/4 of them are growing up in families with undocumented members, right? This is happening during a time where our immigration enforcement policies have become increasingly harsh. For these children, the experience of the threat of deportation, the very physical experience of family separation, the constant vigilance that their families live under, in which they have to undertake daily family routines, aware of the possibility of immigration enforcement activities. So that is the reality. We have a robust body of research that has shown that children living in these families are experiencing a lot of mental health issues as a result. And that extends not only to children that themselves are undocumented, but again, this is an issue for mixed status families. This is an issue for US citizen children in these families. And we know that they're suffering some of the mental health impact as well. So as I think was said before, this is I think a very profound, really profound and often overlooked equity issue that we need to be discussing more and more, I think.
Let me turn to another question. There was reference, of course, to public charge and to the chilling effect. Even when the policies change, the residual lack of trust remains. One of our listeners asked, what do we know about best practices for or otherwise opportunities for rebuilding trust when it's been broken? Any thoughts on this? Anyone working in that area that could?
So I can say.
Go ahead. Yes.
I can say a few words. I mean, we had there earlier in the 2000s, or no, actually, it was even before that, in the late 1990s, there had been another period during which public charge became an issue. And at that point, I think it was the Clinton administration took firm steps to basically say we are eliminating public charge. It should not be an issue with respect to Medicaid or SNAP participation. And what happened was things got better. There was a period during which there was a very clear chilling effect. In fact, that was when the term the chilling effect first came up, was in that period. And things got better as we tracked over the years the participation of non-citizen children in citizen families and of citizen children in non-citizen families improved considerably. So things can get better over time, but part of what it takes is time, consistent communication, use of trusted sources to deal with it. And then part of it has to do with the general background of not specifically public charge, but the extent to which there was fear in the immigrant community for so many things. And that was an unfortunate artifact of the Trump administration, in which there was fear across so many dimensions that made people afraid to do anything. To the extent that we can establish more trust specifically with respect to public benefits, but more broadly, then I think that will help make things get better over time.
Speaking of trust, there was a question about federal data collection. Of course, we had this whole discussion about collecting immigration status on the U.S. Census, but the questioner didn't ask specifically about that. Particularly among the researchers, when you're looking at trying to answer these critical questions, are there data gaps that could be overcome? Now's your chance to make a pitch for better federal data infrastructure and more opportunities for papers in health affairs. Does anything stand out? If not, I'll keep. Oh, yes, Arturo, please.
Well, I can actually talk about that because I do have made a lot of inquiries on how we could potentially improve data collection among immigrants. And the problem with that is that there's this issue of distrust of whether the data collection is reliable and is going to be safely kept. We in the immigrant research community, we do have ways of trying to estimate measurement error by comparing certain sociodemographic and healthcare utilization of immigrants versus those who are native born in order for us to kind of see how much of this measurement error exists. And I think that, yes, we expect in the years to come to potentially increase our amount of measurement error that we will estimate from this campaign of trying to create this new question in the census that definitely discourage not only immigrants, but US-born families who are related to immigrants or who are of racial and ethnic minorities to answer the census accurately. So it's definitely going to be a challenge, but we hope that over time the federal government will become a little more inviting in trying to generate this trust to immigrants and other populations in order for them to respond accurately to census forms and surveys such as NHIS or MEPS.
Actually, while you're speaking, someone sent in a question. I haven't had time to read it, but I think it's the same question or it's a variant of a question that popped in my head. Your paper you drew on the California Health Interview Survey, which given California's demographics, gives you deeper insight. I wonder, you just talked about the trust side of this. I wonder if you could talk about the subgroup analysis and what would be necessary. After all, we talk about immigrants. We know it's a tremendously heterogeneous population. Is there more we could be doing just to disaggregate this so that we weren't lumping together those who are coming with very low skill and really struggling, and others who come with high levels of education and from different countries and the like?
Yeah, in the California Health Interview Survey, we are able to identify who has a green card. That's a great difference to national surveys. So that's definitely helpful in trying to proxy the immigration status of those without a green card. But there's definitely some range within that non-green card holders that will need to be teased out. And I think that the California Health Interview Survey has over time improved the ways that we can identify those who are undocumented from those who are not, but lack a green card. Some ways to do that is by identifying the country of origin, for example. Others are like by using program eligibility that would not be available for immigrant populations. But still, like I have done research with some of my students on the amount of measurement error and distrust in answering cheese surveys on this question, and there's still some hesitancy in when it comes for this question whether it's going to be used safely and is not going to be some type of like leak that will compromise the immigration status of either the immigrant or their relatives.
Okay, I want to ask. It's a fairly long question. I kept feeling this as I listened to your presentations. Really, all of you talking about, fundamentally an advocacy question of equitable treatment, equal treatment, breaking down some of the policies that are barriers to people being healthy. And I was left with this question that's gnawing at me, and it has to do. It starts, Arturo, with your comment that the geographic location of immigrants in the United States has spread from earlier years. We had a paper presented last week in the session on borders about U.S. citizen children living in Mexico. Leighton, you spoke about, and many of us use the term mixed status families. You had empirical data on differences within the same family. And I keep wondering, and I'm thinking, Dolores, of your sort of the structural racism elements of the hierarchy of need. Is the focus on citizenship helpful or potentially harmful to trying to address the challenges of the immigrant population? On the one hand, you say, these are citizens, we're not treating them well. But that then makes it seem like it's okay if we're not treating people who aren't citizens well. So we sort of elevate, we reinforce the elevation of the citizen by doing that. Similarly, some of the policies come from knowledge and awareness of people who are their neighbors. And as there's geographic dispersion, that changes who knows whom. So this isn't one question, it's much more philosophical, but that's just sort of where I went. How do we approach these issues from the perspective of people with needs and not recreate the hierarchies as we talk about citizen versus documented versus undocumented? Anyone who wants to take that, I'd love to hear your thoughts.
I think that's an incredibly important issue, Alan, and something that I struggle with literally every day that I think about this topic and I work with my team on this topic. I think that we can adopt a number of different perspectives to look at this issue. We could adopt a child rights perspective, a health equity perspective, and that would really call for thinking about giving all children access, right? And we actually tried that approach, and there is actually some interesting documents from the UN Convention on the Rights of the Child, specifically about children in immigrant families, and really outlining that they need to be able to access the same rights as other children. However, I think that we have focused on citizen children because of practical reasons, and really mainly from the policy advocacy colleagues that we have, not we as researchers really understanding all the nuances, that really people gravitate towards the concept of citizenship. Each time that you read about these issues, people always have a note, actually several of the papers in the special issue, that the likelihood of these policy changes that we are discussing is low, right? If we were not to focus on citizen children, it may be even lower, right? So there is a tension there, a very real one, between a broader, more inclusive child rights perspective and equity perspective and the practicalities of focusing on citizen children. For the work that we are doing with Unidos US, we are focusing a lot on citizen children. We don't even have time to discuss some issues of non-citizen children that I'd love to talk about, again, because strategically that seems to be a little bit more hopeful.
That's very helpful. Yes, Brandy.
I think kind of tying in some of Leighton's great points and our work as well, one way to think about it is that many non-citizen children will become citizens and stay in the US. So if you take a more long-run perspective, we know that gaining public health insurance coverage among children has these long-run effects on socioeconomic status, on health at midlife. So if you kind of take that long-run perspective and recognize that many non-citizen children will ultimately be citizens in the US when they're adults, then allowing those children to enroll in public health insurance coverage could actually make them healthier citizens later in life as well.
Yes, Leighton.
So let me add, one of the reasons I've liked studying the issue of immigrant status and citizenship is obviously we know there are so many health equity issues. There are issues that are related to race, gender, social position, economic condition, structural racism, etc. But many of those things are hard to deal with and control, whereas in fact, divisions that we've created relating to citizenship, they're entirely socially made. We made those laws and policies. So we have it within our capacity to change those laws and policies to make things more equitable. The problem is that there are many forces in the country that would try to actually make those differences even larger, that want to say there are bigger differences that essentially are anti-immigrant forces. And that is part of a different underlying challenge of how can we try to make things so that we have more inclusive societies, so that we don't necessarily have these legal policy differences that were entirely constructed that don't necessarily apply in other settings.
You know, Elaine, I'm struck you without a blinking said in your comments, we don't ask people their status, which of course is what we all would have expected. And yet, as Leighton points out, in all of these other policies, that's a choice that we do ask. Are you under pressure to either change that, or is there concern that people want to know how many resources are going to different subgroups based on immigration status or documentation status, or are you able to just sustain that as part of your social mission?
Well, one thing you have to keep in mind is that we are in California, which is a blue state. And no, we are not under pressure to ask our patients their immigration status. And we're sensitive to the concerns that might arouse in our patients around coming forward for healthcare. So we don't want to add additional barriers to our community accessing care that they need. So, you know, that's something that's a deliberate choice and not something that we plan on changing.
Other thoughts on this broader topic of subdividing or creating sub-hierarchies within? Arturo, yes, go ahead.
Yeah, I think that following up on Elaine's comment, I think that there's also ways that at the state level, we can try to offset those divisions by creating policies that try to create a health system that is more inclusive at the state or local level. And one example, and again, following on the California's experience, is the inclusion of young adults who are undocumented for Medicaid coverage, as Brandy studied in her paper. But also recently, there's legislation and some budget allocations considered for older, low-income, undocumented immigrants in California. And as I mentioned in my presentation, this is a population that it will become a source of concern of policymakers in the years to come. If present trends continue, we will need to be discussing how we will be able to protect these undocumented immigrants when they get older. So studying on how these changes could be done could be a first step in trying to approach solutions when the time comes when we can finally have some solution for everyone else in the rest of the country.
I received a question, and it's a reminder again that these various status designations intersect. Someone asked about immigrants with disabilities, a group again that potentially is at greater vulnerability due to lack of access. I don't know if any of you focused particularly on that population in your work, or Elaine, if you want to comment at all on how your system responds particularly to the needs of people with disabilities.
So I'm not sure what the specific question is, but clearly many of the people that we serve do have disabilities from having had chronic illnesses like diabetes for so many years that have been untreated. We have a disproportionate number of people who have amputations, who have lost their vision, who are on end-stage kidney dialysis for end-stage kidney disease, and they bring additional challenges in accessing healthcare to the table. So some of the things that we do to try to meet their needs is providing transportation, providing significant care coordination and healthcare navigation support, providing behavioral health support, just trying to make it easier for people to actually use our convoluted, fragmented system, and also bringing all of the services together in one place. So we've started a multi-specialty medical group that includes behavioral health, medical care, primary care, and the various different specialties that our patients need. And I think one of the myths that frustrates me quite a bit is that all our underserved communities need is primary care. They have the same continuum of healthcare needs that every other community has. And in fact, they have more healthcare needs because they've gone without for such a long time. We need to bring the full continuum of services to these communities.
Well, I'm glad you took us in that direction, because it leads to a last question I want to ask, which is, you spoke from the perspective of a health system, but our other panelists are in research positions. Much of what you talked about was the need for policy change, which I completely understand. But I wonder, with the ear of maybe a less experienced, less committed health system leader, what advice beyond policy change might you give to the health system, the health sector, based on the work that you've done? What can it do to reduce some of these disparities and inequities beyond the question of advocating for policy change? Any thoughts for healthcare delivery?
I think it's really important that people that are in the health system understand the very intricate connections between immigration status and access to everything, right? I think that how one's immigration status can limit their access to housing subsidies, to SNAP, to claiming the tax credits, etc. This was obviously really important during the pandemic, and there was a significant gap of nearly a year of people not being given the stimulus payments if someone in the household didn't have a social security number. All these really very, very specific details are different for each policy, are hard to understand even for people like us that have been focusing on these issues for a long time, right? It's very difficult for a health provider to be able to advise a family on this, or for a social worker that is part of the health system. And I really wonder, and this is a question for Elaine and everyone else on the panel, how a health system can try to streamline some of this information and guide families to the use of these different social services. In some cases, they do have access, they are eligible, but there may be a million reasons they are afraid or not aware of their existence, so they forego them with consequences for everyone in the household. But it's really about how a health system can make a really complicated policy issue manageable for their providers and in turn for their population that they serve.
So I would say that we really need to customize our health system and the services that we provide to meet the needs of our population. And, a couple of examples of what Dolores was talking about. So we have a small hospital that's space constrained, but one of the things that we've done is we've allocated space in our hospital to county social workers so that the people that come into our facility can be screened for their social needs and enrolled in programs that are available without having to go somewhere else and within the four walls of a trusted place where they're coming. Where we also provide a very large team of social workers and health navigators and promotoras to help connect people in the community to a range of social services, including a food access program that we fund and operate ourselves. So I think it's really just customizing the services and the environment to meet the needs of the patients that we're serving in our community. And as she said, making it simple and convenient.
Sharon, I'll give you the last word.
Thanks. I was going to say the other thing that we're part of Cambridge Health Alliance, and one of the really important things that they have done is really build out their interpreter services department. And so they make sure that that no matter what language you're speaking, you can get care in the language you speak best. And you're probably also more likely, even if you're registering for care or just reaching out with questions, that you have the ability to speak to someone in your own language, which is like a huge barrier for, I don't know if anyone of you has ever tried to access care in another country in a language you don't speak. I have, and it's really challenging. So you can just put yourself in the shoes of someone trying to access a system and not having appropriate language and translation services available. And so I would say that would be a really important piece. And the other piece I'm thinking about lately as well is just continued education for the workforce in healthcare about who they're serving, where they're coming from, what some of their needs are, their cultural background they're bringing, because all of that comes to play in how they should be approached, how they should be communicated with, and how healthcare should be delivered.
Thank you. Well, I'm going to bring us to a close here, thanking all of you for your papers and your presentations. Dr. Batchelor, thank you for your remarks and what you do every day in the healthcare system. Arturo Bustamante, again, thanks for your leadership on the issue. And our funders, who I believe will be up on a slide in a moment. But just to remind you, the California Healthcare Foundation, the California Endowment, and the Conalma Health Foundation. I just close by saying that there is so much talk now and action, but talk particularly in the healthcare spheres about the need to pay attention to equity. If there's one thing that we take away from today, that if you're serious about health equity, one dimension of inequity is immigration. We're not just talking about legal status, we're talking about immigrant health broadly. And if you are interested then in equity and it takes you to immigration, you have to see that we have many policies that are not necessarily squarely in the realm of health policy that have a significant effect on the health of immigrants. And so as the health sector tries to tackle the topic of equity, it needs to focus not just on this population and not just, although there clearly are health policies related to this population, but to the broader policy environment that is a burden on the health of immigrants. So with thanks to all of you, thanks to our listeners for joining us today. After the event, you will get a link to a survey, which is part of our efforts to improve our events and to broaden and diversify our community. So I would hope when you get that link, you will complete it so we can design better events and products for the future. Thank you all again for joining us, and we're at the end of our program.
Thank you.
Thank you.